And that was an amazing demonstration of that.
Thank you.
So thank you, Serhat.
Thank you, France.
So now I would like to introduce our next speaker. I don't have my clicker. Our next speaker is Dr. Edgar Elshar. So he is, thank you. So he is a periodontist from the US, from New York City. You have a private practice there.
Yes,
You've been involved for many years as a program director, actually, at NYU, and you are now a clinical professor at UPenn. So you're also very involved in the academics, and of course also an ITI fellow. So today you are going to talk about extraction socket management, alveolar ridge preservation. We know that you have published about that, and we're really curious to know what you have to say about that. So Edgar, the stage is yours.
Thank you for the introduction, Dr. Lambert, and thank you for Straumann for having me. I want to second what my colleague has said about Turkey and add to him also about Syria. The poor people have been suffering for so long, the last 12 years on top of it. So our prayers are with you, and I hope that you give me the time for that. So I'm more than happy to be here with you, and I want to discuss with you the management of extraction socket. And matter of fact, I always like to say that we have a trilogy in dentistry, implant dentistry, aesthetic dentistry, and oral health. It's always going to be here. It's never going to disappear. And since we are more into an implant forum, in order to us to put an implant in the most wonderful, exact aesthetic position, one has to refer to either ridge augmentation or site preservation. And all of that are important because that's going to lead us to peri-implant health. And the peri-implant health is important because this is what will keep us away from peri-implantitis that will be discussed later on, or even complications that you're going to see throughout the whole day, how we're going to fix them. So with that, I made a small PubMed search, and you can see that there's almost 2,000 articles published about the extractions. And nobody agrees on anything with that. So everybody has their own way. So I want to walk you through and see my experience with it, how we can hopefully help you with the management of the sockets. But we all know that there is a fact that if we don't do anything and we extract the tooth, there is a site deficiency that is going to take place. So since I am an ITI fellow, ITI has put out what we call the SAC classification. And in that SAC classification, you can see that there is also a modality of treatments as a type 1, type 2, and type 3, and type 4. So with that will lead you, it's based basically on time. But nevertheless, they made one thing that is extremely important, which is the risk factors. So let me walk you with one case that can be prominent for something like that. So I was referred this case from a very dear colleague, and when I got the case, I called him up and I said, what have I done to you to send me a case like that? Because in reality, this will embodies everything that is horrible that can happen. You have a resorption, you have a lot of things, and then we're going to take that ITI risk factors, and you can see in it that there is a high scallop and a very thin scallop, and also triangular one, and even further, we have less than 1 millimeter. And these are all the criteria that will tell you not to do the type 1, but rather to focus on type 2 and further. But is this the right answer? Because if we look at the criteria of the ITI, we can see that also from the same group here from Switzerland, they published that less than 4.6% have equal or over 1 millimeter. So I don't know how this criteria can work. But nevertheless, the second important part of any extraction socket is the bone graft options. I am more focused on the allograft, and I'm going to focus on that, and in particular about the mineralized bone. But throughout my journey, I have published a paper about a DBM, which is a putty of allograft. And in that was one of the first about extraction sockets, because extraction sockets are totally different than all the studies that have been done about sinuses. And this is where it's more contained. As you can see, most of the biomaterial been tested in the sinuses. With that, I like histology. I'm probably nerdy with that, but I love it, and I lived through it. And if you look at it, and this is for me, whatever artist you like, is it the Van Gogh or you Picasso or whatever you like, this is for me the best piece of art, because here you can see the activity between the osteoclast resorbing the residual graft, plus the osteoblasts that are opposing it, and the activity inside between the secondary osteon and the osteocyte that they are filling up the lacuna, and the lines, the purpley lines that shows you the amount of remodeling. And you can imagine from my sound, I'm getting too passionate about it. So this is for me a real bone. This is what we are looking for as a implantologist, as whatever we are, a periodontist especially, because we are a little bit finicky about histology, but nevertheless, that's what we're looking for, a live bone. Further to that, the same group there where I came from NYU originally, and from who have written the papers about the sinus, who put the sinus on the planet, and we talked about BIOS, xenograft. Then the same people did a study bilateral comparing a xenograft BIOS in particular versus an allograft, and they found that there is twice the vitality with the allograft. So these are the same people talking about it, and the most important is less residual material. And moving along, a very dear friend of mine, an oral surgeon from California, Backley, he used to do the cleft, and he said, with the presence of allograft, this is like a godsend. I don't have to do it anymore, going for the iliac and so on and so forth. Leading last to Nevans, where he published in the sinus, and the sinus are more predictable, as I'm sure, but nevertheless, in the mixture of cancellous and cortical, this is when we started looking at the mixtures, and there is more vitality and more stability. But I am, again, another nerd. I love medical articles. And in the articles of the medicine, you can see in trauma in particular, they have tested the cortical bone versus the cancellous. And you can see that the cortical preserve the shape, cancellous resorbs. So you have the two. So that's the opportunity for us as a clinician, is to manipulate the biology to our advantage. You want volume, you use cortical mineral. You want more bone, you take more cancellous. You can mix them both, you achieve the same thing that we talk about, the volume, 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 volume. So I have written a paper about socket classification and how you manage the sockets. Now, I was a little bit ahead of the curve. I have to give myself a little bit of credit. But nevertheless, in 2016, I mentioned the biotype in extractions. And now, after the World Workshop, we know that the biotype or phenotype is the most important point for us in the assessment through the diagnosis. And then I added the grade 1 and grade 3, and each one has their own way. So I am not going to talk a lot about the immediate. Dr. Lombard is going to talk about it. But back in the day, I published one of the first papers about immediates with amounts, and we had 98.77 in a periodontally involved patients. So I'm going to focus more on the grade 3, and one of them is an anterior socket. And when we talked about tissue, lovely presentation before me, about the importance of the soft tissue and the bone. So here you're going to see how we can combine them both. And this is a central that presented to me from a patient that moved to Chicago now, but nevertheless, he had a fracture on the central. And you can see there is a loss of interproximal bone, which is a very challenging point, and that's what I considered in my paper, the topography of the apex, the interproximal bone, the biotype. And if you look at it, it is a little bit triangular, not little bit, more triangular, and that means the proximal point is more incisal, and it makes the distance from the papilla to the bone extremely long. And definitely, if you draw the lines around the tooth, you can figure out what I'm talking about. It is, in one tooth, you have everything in it, triangular, square tapered, and square tapered. So This is when you take the tooth out, you can see the amount of bone loss on the interproximal. So how can we manage that? We wrote a paper, is an amendment of the original paper that's written about rotated connective tissue. And what we do is we take connective tissue from the palate, still pediculated, but we take them further away. And then we de-epithelialize and we rotate it over. And then we close the socket. What it does, it increases the amount of soft tissue and at least preserve the scallop. And from there, you can see the case, the extraction was done, the bone graft was done. It's an allograft, cancellous cortical mixed. And I use the pediculated connective tissue. Temporary fix is extremely important. And then we move along for the healing. And when time comes, and you can see this is a very old case, because I did it with the co-diagnostic, the original co-diagnostic, and that's, I'm revealing my age at this point. So this is the version 8.0, and we used the Gonix table to make a guide. So I don't know if any of you in the room remembers Gonix table, but I can never forget it. So nevertheless, so we moved along, we placed the implant, and you can see this is a very old case because that's before the Loxim. And then we placed the implant, we let it heal, and then you can see the scallop that was formed through, again, with the temporization, and then we restored it. And to see the difficulty in this case, how it was achieved by adding the soft tissue to the bone. And this is initial, and that's post-placement, and that is also from the, from the profile. So the patient has moved to Chicago, and soon, I was coming here. I said, well, can you go to your dentist and take an X-ray? And he sent it to me. And this is a 12 years follow-up on it with stability. He tried to take a picture of his mouth, but it's not quality for me to show it to you. So moving along in the socket preservation, I'm going to move to the grade 3 and more of a ridge augmentation kind. Because when we are dealing with the socket, we're not only dealing with just a graft of a socket. Sometimes the socket is beyond the realm of a socket. And if we take this case, she had a fracture. And sure enough, in my protocol, I take CBCT. And you can see there's no buccal plate. And there was no placement of an immediate implant at that point, meaning immediate implant, the time of the extraction. Let's be clear with the terminology. So I did an early implant placement. So it's a delayed placement. So I take the tooth, let the soft tissue heal. And then I approach with a flap. And then I open it. And again, you follow the protocol of the ITI, which is the 4 to 8 weeks wait time for the soft tissue. And from there, I can place the implant in the position that I like it. And as you can see, following also the protocol of ITI, I'm very specific today to follow the protocol of ITI. And you look at the Loxim, and the Loxim has to be a certain amount of depth, which is the 3 points from the adjacent teeth. And this is the beauty of the allograft. So now you place your implant, you are in a U-shape defect, contained defect, and I know that the concern about the volume. So sure enough, this is the allograft. I don't have to scrape for autogenous bone. I have the allograft, and that's the beauty of the allograft cancellous. It turns red. It soaks the blood clot. It holds it in place because the wound healing, it is based on one thing and only one thing. It is the blood clot. It starts there and everything follows. And I have done a lecture yesterday for an hour and a half. You can see it on the platform of Straumann. You can see more in depth my thinking and thus concept. And I add the cortical bone. Cortical bone creates the volume. The cortical bone does not resorb quickly. I correct my word. It does resorb, but not quickly. And it does overturn. And that's what is important for us as the clinician. I don't want to see a graft in my mouth 10, 12, 15, 16 years. And if you go to my lecture, you can see histology of 10 and 20 years, 18 years actually, of about Xeno, that you can see it still there and will always be there. But rather, you take an allograft, it's not there. It's your own bone. And that's what we need to move forward with it. And then I do my membrane. I do the basis of augmentation, which is stabilization, primary closure. I don't do vertical incisions in my flaps. And then this is at 6 months later. You can see the amount of bone, and you know that is bone. It smells like bone, feels like bone, and it's bone. And I have it as a proof on histology. So this is the tooth restored. Sure enough, fractured the tooth next door. Now I had the opportunity to take a CBCT 5 years later and look at the bone. The bone is there, the volume is there, and it's still working. So I don't need to go for any other biomaterial to grow volume. And here we did it the other way because we had a buccal plate and we had an apical topography was not very conceivable. So I grafted it and I came back and I placed an implant, and you can see the good amount of bone that you can create with the allograft without even going too fancy in the approach of the socket. And that's the second stage. Again, management of the tissue. We have tons of tissue. It's very important. And then you can see in this picture, one was with guided, one without guided. The one with guided was number 13, which is the second premolar. One non-guided with the first. You can see that's before I came back into the 3D printed guided. So finally, my final case is here. This young man was skiing, hit his mouth with the sticks, and fondled around between dentists here and there until, believe it or not, one of the biggest seller used to be the head of biomaterials of one of your competitor company. He was his high school friend. Tell him you go to Elchar. So I came to me and I told him, but guess what? I'm not using your own bone. I'm using my own bone. So that's how it worked out. That was the deal that we did together. But you can see the amount of deficiency. This is the socket, goes outside the ROM of a socket. And sure enough, you can see he had a very class 2 defect skeletal. So we took the tooth out first, let the soft tissue heal. That's a ridge augmentation. You can see the amount of volume that you go. And then I did publish a paper about titanium mesh, but in that paper what's important was the 3D printing. I 3D print the defect. You can see this is a through and through. And then I wax it up. I trim my titanium mesh, prepare it ahead of time. I go ahead, put my bone layered, allograft. You can see how intense it is. The nasopalatine is in the area. And then you have to enucleate it, close up put the titanium mesh, secure it. This is a medical grade, 100% allograft, no membrane to cover it, primary closure. And that is the healing. We go ahead and look at it. That is bone. 100% allograft, titanium mesh, open pores, no membrane. And I can't defy you if you can find something like that with anything other than allograft. I didn't go to autogenous bone in that case. So placement with guided, and then from there, you let the soft tissue heal, you manage the soft tissue, lack of time. I'm gonna tell you this is the result, and this is over 2 years with good stability, both soft tissue and bone. With that, I'd like to end the lecture and say the 3 cardinal points for the extraction socket is the wall sets the tone for the bone sets the tone for the soft tissue, and the soft tissue sets the tone for aesthetics. And I always like to use Sha'arisms coming from my last name. And this is for you, Antonio. Fundamentals never change. Biology always wins. Set your goal and walk your way back. Thank you very much. I came up with the book. If you want to see more about me, you can look it. And these are